Right, so Dr. Lalit needs no introduction. He's given us terrific scientific feasts in the past. He's going to speak on oops in vitreoretinal surgery.
Thank you for including me in this session. It's one of my favorite sessions where oops occurs. Oops means sudden jerk occurs during surgery. Because I had followed this session way back in DOS when I was secretary of DS more than 2 decades back. So there's no financial disclosure here. So since I'm a retina person, I'll talk oops moments in VR surgery. In contrast to, I think all surgeries are challenging, but VR surgeries are slightly more challenging and all cases are different. Many patients, as gray hairs increase, the more VIPs you have to tackle. In fact, patient demands expectation are so high thanks to all the cataract surgeons. They promise instant recovery, but VR surgeons can't actually give instant recovery in a lot of these patients. And more they want to join back duties immediately. They say, Dr. Gaurav surgery, same day join kiya, retina you can't join immediately. Because that's what, they understand eye as eye, they don't differentiate. First, then consumer cases are on our heads. So any one oops moment, 10 cases are filed against you. So there are a lot of, oops moment in VR surgery. But what I believe is very important for all of us clinicians, all complications are bad, there's no doubt, but they do happen, they happen with everybody. But whosoever operates can face, but surgeon is best known how he handles that situation. That is the crucial part. So I'll just demonstrate one video here of oops moment. This patient had an RD. You can see there are, synechia which is broken. There is a pigment on the surface of lens. So I did check the cannula. Cannula was in the vitreous cavity. So I was doing this vitrectomy here. Suddenly the glow became less. The cannula has become, the light has become subretinal. But I did not remove the light because the frequent change of instruments can cause issues. You can see this reg component, regma component here. A lot of pigment. This was a surgery which I already done before. So with the right hand, I injected PFCL. Whatever vitrectomy I could do, I did this because base resection. Since I was not able to carry on more, I put in a chandelier here. And then suddenly you see the light has increased quite a bit. So I carried on with my vitreous surgery, membrane dissection. The goals of, there you can see multiple breaks here in the upper part. The one break in the lower part, this PVR membrane we dissected. So that was actually not very challenging. So then I proceeded to remove the PFCL. Once I removed PFCL, retina got balloonous. And you notice in the lower part, there's subretinal air coming up now. So if your day is bad, you can have all complications. So I checked the cannula again. This cannula had now become again subretinal, the inferior one. Previously, the upper nasal had become subretinal. Now this became subretinal. Now we have 5 openings in the vitreous cavity. So I lifted this, removed this. First and foremost task was to remove this subretinal air. And once this air came out, then the job became easier. Then we had air in the vitreous cavity, and retina got settled reasonably nicely. Then we lasered all the breaks, 4 breaks pre-existing, 1 iatrogenic break which got created during this oops moment. And then we lasered everything. And that was the end of surgery. Fortunately, this patient did well despite the oops moment. A small one more clip I'll show. This patient did not have much PVR, but there are 2 star folds here. So after doing the vitrectomy, I started, doing this membrane dissection. And my favorite instrument is this 25 gauge micro pick. So we started this, trying to tease off this membrane, because you have to free this membrane from the surface of retina. So I was doing this, then took this forceps to pull. I think this was the wrong thing, that keep pulling till the membrane comes. Sometimes keep pulling, retina may break also. And this is what happened. You see there were warning signs here that you see focus is on the membrane, but you see the surrounding retina. There are hemorrhages here in the close by. and suddenly, oh, so this was oops here. So what now? Now is then, pray for some time. God give you enough wisdom to proceed. So this membrane was actually very, very tough. It was not coming with usual whatsoever we are used to. So what I did was, after having done some hemostasis, some laser, I shifted to bimanual because this membrane still won't budge. So I did this scissors and took off this membrane. But this was not the end of it. So with bimanual, this membrane I could able to dissect. But there was another, membrane which this was another interior, this is further interior. So this time I took precaution that I will not use forceps till the time I release all the membrane with the tangential use. So once all the membrane was freed from the surface of the retina, so comparative to the first membrane, this membrane was not so densely adherent. And it obeyed my command of, removing this membrane. So you have to be very careful. You have to titrate your pull vis-a-vis what's happening to the retina. So very slowly, gently remove this membrane off the surface of retina. Then follow the same principles. And fortunately, this retina went back. So I thought these are the couple of oops moments in retina surgery which I'll share. And I will now stop this video here. So oops moment do happen, I think, in all surgeries, but maintain your peace, maintain your calm, tackle them, and as I said, surgeon is known by how he tackles. Fortunately for me, both these patients did improve to 6/18, although we created a big tear in the second patient, but that also till date is doing okay. Thank you so much. Yeah? Yeah. So you are right that we should not start any case without 6 mm. In fact, I was remembering. The other precaution which you have to take is in such patients where there is hypotony, uveitis, pigment, so have a straight entry rather than having a beveled kind of entry. So beveled entry, you lose some length of the cannula. So if you go straight, then you will enter direct vitreous cavity. So you're right, in some of the cases we use, especially in endophthalmitis, where the choroid is boggy and thick, use 20 G.